We strive here at St. Francis to have a very, I wouldn't say predictable, but organized plan of care for a patient from the moment they hit the door to the moment to when we decide what needs to be done. And we usually set a goal for ourselves that from the moment the patient comes to us, within 2 weeks, they will be worked up and ready with a plan.
Many of these cases are extremely difficult, and it is very helpful to have oncologists, pulmonologists, and surgeons look at this to decide the very best treatment possible.
Typically what will happen is they will be seen in consultation, say by me. A plan for intervention diagnostics will be established. The patient will typically be scheduled for bronchoscopy with an airway inspection and an endobronchial ultrasound for staging if there's a tumor that we're dealing with. They will undergo the procedure. We have on-site cytopathology usually, and if a cancer diagnosis is apparent, we know immediately during the procedure. That is conveyed to the patient. A solid tumor coordinator is engaged. We have that in St. Francis. And from then on, the care is coordinated. Whatever further testing is needed to establish an accurate stage is implemented.
Once the patient is staged through various studies, EBUS, we have a pathological diagnosis. We discuss them in the clinic. We review the CTs, discuss what type of tumor that they have.
It's not a simple process, staging. You have to understand all these factors, the T, N, and M, and how they combine together to give you a stage. And it's not something that somebody who every once in a while does it can do it properly. So it is pivotally important. It is vitally important to properly stage the patient, and it is vitally important to stage the patient in general to offer them the best treatment.
How much surgery will they tolerate? We have some people that will only tolerate what we would call a wedge of the lesion only and not remove the entire lobe that the lesion is within. We can do that. There are some people that have a lesion that is so deep in the lung that it cannot be wedged out only, and in order to remove it, you would have to remove a substantial part of the lung, and in that case, they could not have surgery at all.
In order to remove lung tissue, you have to have a reserve in lung tissue to be able to function without that part you're going to remove. And the only real way to determine whether there is enough lung tissue other than clinically talking to the patient is to perform complete lung function with oxygen exchange capacity called diffusion capacity. This is very important because there are certain criteria that we adhere to help the surgeon understand whether surgery is possible or not. There are certain parameters below which if you go, the risk of bad outcome with surgery, including death, is extremely high. So that's something our surgeons will rely upon us to look at before they even touch the patient. And in some cases, these values are very in the gray zone. They are low, but not too low and not too high, and you really don't know, and you don't know how much lung tissue you can remove. And there are other things we can do, like differential perfusion scanning for the lungs or a cardiopulmonary exercise test, which all is done by us, the pulmonologists here, to determine the risk associated with surgery. And at the end of the day, the surgeon receives a patient with a good idea what they can and cannot do surgically to them.
Thoracotomy is the incision that we make, and it involves division of ribs, usually one and sometimes more, actually spreading the ribs apart where you can get your hands in the chest cavity of at least, this wide. And that type of trauma is extremely painful and will last for some time. We are now able to resect the lung or portions of the lung, even the esophagus, with a scope. And we call this for the lung a video-assisted thoracoscopy or a video-assisted lobectomy. We actually use cameras where we can go within the chest cavity, and rather than having to make an incision this long with division of rib, a rib, or ribs, there are no division of the ribs. You may have 2 or 3 incisions this big, and then the biggest incision that you have would be 4 to 5 centimeters. And the only reason that incision is as big as it is you have to get the specimen out of the thoracic cavity. And you know, to remove a lobe, it has to be that big. And this is a significant advancement as far as surgical care of people. You can have people home in as little time as 24 to 48 hours after a lobectomy or lung surgery, which is huge. Previously, with a full thoracotomy, people would go to the intensive care unit, and they may be here 5 to 7 days. And so it's a great advancement for pain control and how well people do. It's a great advancement in keeping people in the hospital only a minimal amount of time.